Good morning, everyone. I'd like to welcome everyone to today's special OC3PR that will be discussing the emergency standard of care topic. Today, we're being pretty ambitious. We have multiple speakers with several segments, so we're really going to need to be cognizant of our time. We're also using an upgraded form of Zoom, and I trust everyone appreciates that we're not techies by our background, and so bear with us as we experience some challenges, but we're pretty optimistic we'll be able to get things to work. For those unfamiliar with our webinars, OC3PR is Ontario Critical Care Clinical Practice Rounds, which is a series of talks that is intended to help health professionals and administrators in their ability to provide safe, effective care for critically ill patients in terms of medical and management issues, but also in terms of staffing as well as how to organize their ICUs. Our focus of late has obviously been on the COVID-19 related issues. As always, we value your feedback and suggestions, which we ask you to send into the email address info@ccso.ca. We encourage you to follow CCSO on YouTube and Twitter, as well as visit their website. To minimize disruptions today, we ask that everyone try to stay muted. At the completion of the session, there's a brief survey which we will ask all of you to please complete to help us make OC3PR better. In terms of questions, there's now a Q&A feature. Today's questions will be managed by our colleagues, Dr. Neil Adhikari and Dr. Jose Terrio, and we'll advance the slides, please. Both Neil and Jose are ICU physicians who will be monitoring the voting feature. It will also have a way of helping us to prioritize which questions we will try to pursue, obviously with time permitting. I cannot imagine that any of you will have difficulty recalling the often troubling and horrific stories that came out of Italy and New York City, among other places. Advance the slide. It was evident that sudden surges of patient numbers, along with the inherent limitations of transport, that even if our overall resources are sufficient, there can be a distribution mismatch of patients and available resources. Although it is the responsibility of everyone, be they health professionals, government officials, and even the public themselves, to help prevent this mismatch from ever happening, in spite of the best efforts of all, as evidenced by what happened in Italy, New York, and various other locations, this mismatch can happen. How this issue is dealt with is the focus of today's very important webinar. All of us recognize the seriousness of the topic, the sensitive nature with the potential for approaches to the topic being contentious and perhaps even controversial. We ask all to recognize this, but to respect the importance and value of talking about things. Of even greater value is the value of listening. We are hoping to share this webinar as transparency and openness is invaluable for a topic such as this. That said, we ask that parts of it not be shared or reproduced without the consent of Critical Care Services Ontario. As I said earlier, we have multiple speakers who have freely given of his or her time. Advance the slide. Unlike previous events, we will be introducing each of our speakers immediately prior to their respective sections. However, as you can see from the slide, our speakers bring a wealth of knowledge and experience for today's webinar. Our goal today is to have an impact on all of you. As health professionals, we abide by the principle of to do no harm, to save lives, to care for all. Sometimes, such as in a pandemic, the manner in which this care is demonstrated can sometimes change. As such, our hope is for all of us to better understand the why that the emergency standard of care was developed. We would like you to come to fully appreciate the thought, the integrity, and the ethics that have gone into developing this emergency standard of care. There have been immense challenges in its development. It was a complex process that began in the early stages of the pandemic, and it remains an ongoing process today. We want all of you to have reassurance in how it was created, with equity, fairness, proportionality, autonomy, accountability, and other underlying principles directing its creation. We want you to know there is support in what is being proposed, from the available tools and documents to the strategies, policies, and the ethics it entails. And finally, while all of us continue to work hard as we can do our best to avoid the situation which would require an emergency standard of care, we hope it will give all of us the courage to be able to work together as a single unified team to act in an ethical and honorable fashion, to be able to embark on this difficult journey to help provide the best, most appropriate care for all. For those who don't know, I am Dave Nilipovitz. I am an ICU physician in Ottawa. I am lucky again to have Dr. Michael Sullivan as my co-host for today's discussion. Mike is also an ICU physician, and he and myself both are part of the provincial critical care team helping to respond to the COVID-19 pandemic. Before we go to our first guest speaker, though it could maybe go without saying, we all believed, however, it is necessary to firmly establish our most important goal, next slide, which is prevention. To do everything that we can to avoid ever having to enact an emergency standard of care. How we do this is a combination of 3 different strategies. I believe most of the listeners will be familiar with the idea of smoothing, the so-called flattening the curve, to try to avoid a sudden surge of numbers. There's also work being done for capacity balancing, whereby we are moving either resources and or patients to have better matching of available resources to patient needs. The final thing that we are aiming to do is to increase the available resources that are available to help care for all patients. Towards this end, there's been a marked increase in the number of ventilators, the number of available critical care beds, as well as the amount of ability to transfer and move patients accordingly. So our intent was to go into the why, and Mike, I understand that Dr. Baker's unfortunately having some difficulty getting on.
I think we're okay, Andrew, or pardon me, David. Andrew, are you there?
Can you hear me?
Yeah, we sure can. That's fantastic.
Okay. Fantastic. So in this regard, to help answer the why, we're lucky to have our first speaker who's had an integral role in all of the strategies I mentioned to help avoid having to enact an emergency standard of care. That's Dr. Andrew Baker. For those not familiar with Andrew, he's the incident commander of the Ontario Critical Care COVID Command Center, which has been coordinating the critical care response in Ontario. With the success of that table, he's now also heading the hospital IMS command for the GTA region. Dr. Baker is a professor and vice chair in the Department of Anesthesiology and Pain Medicine at the University of Toronto, and has had an extensive academic and research career. Dr. Baker, Andrew, thank you for joining us. I will note that's a picture pre-COVID, and so certainly it's taken its toll, and we look forward to you helping expand on the why. Why, unfortunately, might an emergency standard of care have to be enacted? Andrew, thank you. Thank you again.
Hey, thanks a lot, Dave. I just want to confirm that you can still hear me.
We can.
Yes, we can hear you. Your video isn't on.
Okay, yeah, I'm sorry about that.
Okay, all right.
So can we go to the first slide?
You'll have to speak a little louder, Andrew.
Okay, I will. Yes, I've been faced with the question many times, why would you even think about this? And so I've tried to divide my thoughts into 3 areas here. What is it that we're actually thinking about? Are we thinking about something that's already happening? And what happens if we don't think about this? Next slide. You're unable to, can you hear me now?
We could barely hear you, Andrew, so if you can really try to shout up as much as you can.
Okay. Okay,
Speak as loud. Is that better?
Much better.
Okay,
Much
good.
better.
Okay, I'm sorry about that. Okay, so I want to tell you what I've heard other people talk about when they frame the question. And really, I've heard two themes come through in framing this question. The first one is the scarcity perspective. And that's similar to in wave one, when we didn't have enough N95 masks. If we sort of said to ourselves, gee, this is a problem of scarcity, of supply. And if we could find and produce more N95 masks, we'd give one to everybody. In wave two, it reminds me of the vaccine question. If we had an unlimited supply of vaccines, we would give them to everybody. And so when it's limited, we sort of say to ourselves, we're going to find every single last N95 or vaccine, and we're going to use them. And we're going to direct everything we can to finding those resources. And as it relates to this question, we're going to redirect and find every last ICU bed we possibly can. The second theme that I hear, though, Dave, is what is the most productive application of the incremental healthcare resource? And the people who talk about this say, well, listen, we've got a finite healthcare system. We've got finite resources. We know that in advance. And really the question is not finding every single last resource that we possibly can for critical care. But in a limited system, what's the best use for the next, and in this case, it's probably will be a HHR, a nurse or an RT capable of either providing scheduled care in the operating room or scheduled care in the ICU. Next slide. So the second theme about why would we even think about this is that, gee, this may already be happening. I've heard from many people, including leaders from OH, from Staney Brown presenting on CP24 and others, that the net effect of the system right now is that people with threatened, but better than 20%, 12-month survival are not getting usual access to care, with a measurable negative impact on their morbidity and mortality. So we're being told that this type of decisions, these decisions about redirecting incremental resources are already happening with a real impact on people's outcome. Next slide. The second thing is that the system that we operate in is built on a utility decision analysis of relative productivity in a finite resource environment. So well before any pandemic, we have analyzed the utility of various procedures or diagnostic maneuvers against their relative productivity and made choices. And one could imagine that increased, say, screening tests, colonoscopy, MR scans might have an incremental benefit, but when compared to the use of that resource in another field of medicine, we've decided not to do it. So the system inherently is built on the concept of the best use, the most productive use of the incremental healthcare resource. Next slide. And we all know that this discussion is already occurring in terms of the determinants of health, including prevention versus treatment, and even social versus biological determinants of health. And what I mean by that is many people have advocated that we should invest in the social determinants of health, and that might have a greater return on investment. And inherent in any of those conversations is, again, the most productive use of the incremental healthcare resource. Next slide. So finally, I want to talk about what happens if we don't think about this. Well, people who have studied this tell us that there would be more preventable deaths and went into a situation of excessive men without a plan. There would be more preventable deaths. We've already seen regional and probably socioeconomic inequities in the access to healthcare, and this could turn out to be one of the most troubling things as we look back at this pandemic. And then, of course, if we don't have a plan that has all the benefits that are included in this one, there's the potential for implicit bias and divergent approaches. We may have seen this in other countries. If we don't think about this, I think there's a huge missed opportunity for us as well. A missed opportunity to introduce a systematic way of thinking about incremental resources, which pulls it out of just conversations and into a way of actually measurement. We miss the opportunity to show leadership and introduce both an evidence-informed and ethical and socially inclusive approach. And finally, we miss an opportunity for healthcare professionals, for us, versus politicians or administrators, to lead this already existing issue. So Dave, I think that's really the why of why we need to talk about this explicitly, bring this forward, and have this type of conversation amongst all of our colleagues.
Thank you,
I'll
Andrew.
stop there, Dave.
Thank you, Andrew. Mike?
Thank you very much, Andrew. That was, I think, critically important for us to understand where this emergency standard of care is in the context of what's going on around us and in our current time. Maria, we'll take the next slide. We are now going to move on and talk a little more about the details of what that might look like, specifically the what, who, and how of an emergency standard of care. And to do that, we've got two people who've spent a tremendous amount of time on this topic and really have guided the Critical Care Command Center forward in their thinking about this. So James Downer is a critical care and palliative care physician in Ottawa. Uniquely for a critical care physician, he is currently the head of the Division of Palliative Care at the University of Ottawa. And James holds a research chair, a clinical research chair in palliative and end-of-life care. And Andrea Froelich is a director of the Office of Ethics and Medical Assistance of Dying program at the Hamilton Health Sciences Center. She is, as I understand it, the only anthropologist working as an ethicist in a Canadian hospital. She has other academic interests, including religion, ritual, and literature. And Andrea, I believe you're going to start us off on this topic.
Great, thank you.
Welcome.
Thank you for the opportunity to be part of this webinar today to support our health system, to feel prepared and supported, and to find our collective courage in facing the prospect of a surge in critically ill patients now or in the coming months. And I want to acknowledge that none of us trained for this, and all of us are being challenged to dig very deeply into our principles, our professionalism, and our personal resilience to navigate through the daily moral and physical hazards that COVID throws at us. So my role today is to provide you with some background about how this emergency standard of care came about, to reassure you that this isn't some form of moral improvisation, but it's a practice standard that is more than a decade in the making. In addition, I'll be speaking to how the emergency standard of care anticipates many of the moral hazards you've probably been thinking about as you've been following the extensive news media coverage of this issue. We aim to make clear how the emergency standard of care acknowledges the challenge of balancing tensions between the ethical principles that you rely on to guide your practice in non-pandemic times and the principles that must prevail in situations of extreme resource scarcity, like we are anticipating, specifically principles of fairness, equity, transparency, and saving the most lives possible. As John Kabat-Zinn says, we cannot stop the waves, but we can learn to surf. And perhaps we can't stop this coming storm, but the emergency standard of care can provide some protection to our communities, our patients, ourselves, and our healthcare colleagues to help us weather it together. So this emergency standard of care actually began over a decade ago after the SARS pandemic. A group of scholars at the Joint Center of Bioethics conducted a CHR-funded grant program of research called CanPrep. You can actually find their report still available online. And one of the unique things that they did is they engaged in extensive stakeholder and public consultation asking members of the public, how should we allocate scarce resources in an overwhelming pandemic? And the public said very clearly two prevailing principles. One was to save the most lives possible, and the second was to do it in a fair and equitable and transparent manner that would really engender trust between clinicians and the public. So based on this foundation, the Ontario COVID-19 Bioethics Table convened a working group to work specifically on the ethics challenges related to critical care triage. And under the leadership of James Downer, myself, and others, a draft document was published by Ontario Health and sent to healthcare organizations back in March. Now, this was done precipitously and urgently because of what we were seeing out of Italy and New York City, and there was concern that we would be rapidly overwhelmed as those jurisdictions were. Happily, that didn't happen. And so in the intervening months, there has been very careful relooking and examination and redrafting of that early version to really align with professional ethics and principles. It's meant extensive stakeholder engagement with the Ontario Human Rights Commission, advocacy groups, and community stakeholders, as well as consultation with medical experts to really refine the core tool of this standard of care, which is the short-term mortality risk assessment. On the basis of that consultation, there was a proposed framework for critical care triage that was unanimously supported by members of the sitting bioethics table at the time. That was completed in September and advanced to Ontario Health for contemplation. It then found its way to the Ontario Critical Care COVID Command Center, whose role is to implement critical care triage protocols. And so this proposed framework was protocolized so that it could be usable by clinicians and healthcare administrators at the front line of an overwhelming surge in critically ill patients. And therefore, it resulted in the release of the standard of care last week. So next slide. So I want to acknowledge that as you've been reading the news media coverage and also reading through perhaps the standard of care yourself, inevitably there is a yuck factor that arises because a lot of the practices and principles in this emergency standard of care in some ways go against the tide of our conventional professional ethics. So this standard of care is about overt resource allocation rather than a patient-centered approach to decision-making. It's about reducing preventable deaths rather than saving the sickest. It's about promoting equity and transparency in a population-based focus rather than an individual focus. It anticipates high stress, high acuity, and very short timelines for decision-making rather than a kind of iterative process of decision-making in collaboration with patients and families. It's protocol-driven rather than really leaving it up to the discretion of those bedside clinicians. And I think one of the most challenging things, it puts us in the position very uncomfortably of imagining that we have personal agency in the life or death of patients that we're applying this protocol to. Of course, this is in some ways an illusion because it is the pandemic that forces these decisions upon us, as well as the underlying conditions of the patients and the resources available to us. But nevertheless, it can create a real sense of moral worry, hazard, and injury as we anticipate being the ones to ultimately render a decision. So the next slide shows the ways in which worries about triage are surfacing. In my conversations with frontline clinicians, a lot of them have surfaced these concerns about the enactment of this emergency standard. What about my liability risk? And we're so lucky to have Daphne Jarvis speaking to that issue at the end of our presentation. Is this really appropriate clinical care? Is it evidence-based? How will I put my head on the pillow at the end of the day and live with these decisions and the legacy of them? Won't it take too much time? How do I continue to engender a trusting therapeutic relationship with my patients? What about my professional ethics? And will my colleagues in the system really support me? So in the next slide, I hope to show you that this emergency standard of care has anticipated these challenges and built supports in to address them. So the CPSO has already come out publicly to support this emergency standard if required. It has undergone extensive legal review by multiple legal experts. It is a peer-reviewed and evidence-based standard, and Dr. James Downer, who follows, will speak to the development and its enactment. There's no getting out of the experience of moral injury for us who are facing this pandemic, but our hope is that it can be mitigated by the knowledge that this is going to prevent deaths and that it's a standard of practice that is going to be used across the province. It's very efficient to use once mastered, and it allows you in conversations with patients and families to depersonalize the decision and really to focus on caring for your patient, knowing that in the end, you're not the one making the life and death decision based on this protocol. It aligns with all of those ethics principles that Dave mentioned at the beginning. There are many tools and resources in the MacDrop folder that's been created to really support you in this assessment process, in the enactment, and in your goals of care conversations. And in the end, is intended to engender trust, trust with the public, trust with our patients and families, and trust amongst colleagues, knowing that we are doing the best we can in impossible circumstances and doing it in a way that aligns with transparency, with our principles, and with the best available evidence. So with that, I'm going to hand it over to my colleague, James, to explain the short-term mortality risk assessment and the clinical application of the protocol.
Thank you so much, Andrea, and thank you to everybody else who's able to make it here today. I'm going to sort of dive right into it. And again, we looked over a number of different approaches to how to implement or how to protocolize a triage approach. And we tried to pull together, sort of different ideas about, sort of how to decide about risk and benefit, and how to try to make a system that would be proportionate to need rather than more categorical in nature, while still being somewhat objective and rigorous. And this is what we came up with, was essentially to try to determine what to determine a prioritization system. And to be very clear, this is prioritization, not exclusion, right? And until we are at the point of running out of resources, nobody is excluded ever. It's just a matter of prioritization. But we are looking at essentially 4 different categories of risk. And the risk is based on their probability of being alive, or their risk of death, at 12 months following the development of critical illness. Now, I want to be really clear about a couple of points, because I do get a number of questions about this. The focus of this is on the mortality risk at 12 months, not the estimated survival duration for an individual, right? So we know that it can be challenging to predict survival for individuals, but when we're looking at populations based on published data, we can, I think, be reasonably more sure about risks, and certainly within the ranges, the broad ranges that we're talking about here. This is not based on the estimated survival duration of a person in the absence of critical illness. So many of the people who may meet criteria on the prioritization criteria, in the absence of critical illness, many of these people could live for years, and no one should dispute that. This is about having one of these criteria plus critical illness. Ultimately, this boils down to an individualized assessment for each person. This is not a checklist that applies to everybody, but simply an approach to estimating short-term mortality risk and using tools as appropriate to do that. The clinical criteria, the prioritization criteria, are based on published data where possible, and in some cases based on expert opinion, based on the peer review that Andrea referenced. Okay, could you put to the next slide, please? This next slide is a schematic. 2 slides. There we go. This finger painting here is a schematic of what triage might look like as numbers mount. And on the x-axis, you see time, and on the y-axis, capacity within the critical care system. As you can see, the people in the critical care system are broken down according to their mortality risk: red, purple, yellow, and green. As demand surges, you'll see climbing up that dotted line, you'll get to initiating level 1 triage, where it seems like you're close to running out of resources. At that point, only people who are in the purple, yellow, and green category would still be offered admission to critical care. As numbers continue to rise, you would restrict then to people in only the yellow and green category. And then finally, when you initiate level 3 triage, only people in the green category would continue to be offered admission. Finally, when all of the beds are literally full under this emergency standard of care, you would essentially be randomly selecting among people who meet the highest prioritization criteria for beds as they become available. And that process would obviously continue until the surge abates. So this is just a brief schematic to show you what this might look like in practice. Can I have the next slide, please? For each patient, the triage process should follow some key steps. And first and foremost, trying as much as possible to not make these decisions in a crisis moment is really key. So number one, when patients are admitted to hospital, I know people talk about this a lot, but I think we need to be particularly rigorous about making sure that we do clarify patient goals of care and inform them about the potential for possible triage. If patients have goals of care that are not consistent with critical care, it is really important to flag that early and make sure that that's in place so that we don't end up trying to make difficult decisions in a crisis, but actually have a clear plan set out in advance. When you are potentially applying triage criteria, then the idea would be essentially a two-physician approach. And the way we've written it up would be that the most responsible physician would be determining if they feel that the patient meets or will soon meet eligibility for ICU. They themselves would conduct an assessment of the short-term mortality risk. They would consult a second physician, typically an ICU physician, who would independently determine what they believe to be the short-term mortality risk. If both physicians feel that the patient does not meet prioritization criteria at that current level of triage, that the patient would then not be offered admission to critical care. If there is disagreement on short-term mortality risk, you would use the more optimistic again. So you're trying to sort of establish a fairly high degree of certainty as your standard for deciding that people don't meet prioritization criteria. And ultimately understanding that there will obviously be times when you don't have time to do the full formal assessments. And in that case, you default to your normal standard of care where you would say, look, if you would not intubate or not initiate critical care in this person in normal non-pandemic times, then don't do it now. But aside from that, then you need to obviously proceed to care for this person as you would in the absence of an assessment of their short-term mortality risk. And that's obviously not a situation that you want to be in. Next slide, please. Step 3 obviously is very difficult, the communication with patients and families and SDMs. You have to clearly communicate what the decision was and why the decision was made, and document it, obviously placing a copy in the medical record and sending one to an administrator on call. I don't think any of us should pretend that that's going to be an easy step. I'm going over it quickly for the sake of time, but obviously this will be very challenging, and you may need help from others to help communicate this and support families and patients going through receiving this information. Finally, we're communicating, every facility should have a review committee that would monitor the practice, obviously for the purpose of quality improvement, supporting standardization, and be the conduit for communicating documentation to a provincial portal so we can track how it's being used for course changes and corrections as we go. Next slide, please. This is an algorithmic portrayal of what I just said. So again, the triage process starting at the top, on admission or in the emergency room, identify people who do not want life-sustaining treatment or whose goals of care are inconsistent with that. Document this well and do not initiate triage processes when that's the case. But for those where ICU is potentially on the table, you would be at the point where someone is meeting or nearly meeting inclusion criteria, you call the critical care team or the rapid response team if you have one, establish that the person meets inclusion criteria. If they don't, up to the right here, you either admit or transfer them to the ward, complete the short-term mortality risk assessment so it's actually there and documented should it be needed later, and continue to treat them as needed. If they do meet inclusion criteria, then obviously assess by the physician and second physician, document your assessment of short-term mortality risk, again, using the more optimistic STMR if there is a disagreement. If they don't meet prioritization criteria, admit them to the ward. They're still getting medical care. You're communicating, obviously, with the administrator on call, with the patient and family, providing medical therapy as indicated, adding comfort orders because they are not harmful, obviously, and should be part of any medical treatment plan, and then reassess them if triage does get downgraded. For patients who prefer comfort measures only at that point, if there are palliative care areas that are able to accept COVID positive patients, that would be an appropriate situation to use them, I think, if that's available, and obviously supporting patients and families. For those who do meet prioritization criteria and get admitted, they get admitted for a trial of critical care. Obviously, as we always say, it is a trial, and you communicate appropriately. Can you go to the next slide, please? Yeah, so as I mentioned, disagreements may happen between assessors who are doing independent assessments of mortality risk. And again, remembering that in all cases, the default is to continue to offer critical care. So really, we're trying to establish a standard similar to normal practice where both physicians would agree that the patient does not meet prioritization criteria in order for people to be deprioritized. The discussion, if there is a disagreement, you should try to resolve it by consensus through discussing the actual short-term mortality risk in the context of critical illness, not survival duration. That's a really important point. And again, you may benefit from consultation with experts depending on the underlying medical condition of the person. Okay, can you keep going to the next slide? it is entirely possible that you may not be certain. I think you need to be upfront and honest about that, right? If there's a situation where you just don't know, you don't have enough information, it's important to indicate that, and then also indicate that probably the person should be receiving critical care pending a reassessment if it would be otherwise indicated. But also be very clear about what information you might need and set on a path of trying to gather that information to resolve the uncertainty. Next slide, please. There is a templated documentation provided, and we'll be updating that based on feedback that we receive. But the documentation is meant to help walk you through the process so that hopefully you won't miss any steps and keep everything objective in front of you that you can use. It includes obviously 2 copies of the short-term mortality risk assessment, a summary and care plan, and then ultimately try to use the documentations to guide the approach. Please take a moment to review these documents before you need them. Not a good idea to be cracking them open for the first time in a crisis. So a good idea to just get ahead of that. Next slide, please. Okay, so many people on this call who may not operate in a critical care area might be asking, okay, when to assess criteria? Do you only wait until they meet eligibility criteria? And that's probably not a good idea to wait. Again, you should not be making triage or deprioritization decisions for people who have not had full assessments done. Informal or casual assessments may lack rigor and they can anchor future decision making. And so it's probably best to avoid these sort of informal assessments. But early assessments before they become critically ill will be very helpful for things like bed planning or establishing what information you might need to get some more certainty. So probably a good idea to try to get ahead in many cases of some certain situations. And so this is less time pressured. And again, you also don't want to do it on literally everybody because these are not going to be easy conversations and they may compromise the therapeutic alliance and cause frustration. And it's probably not feasible to do it for literally everybody admitted to hospital. So we're just going to propose a bit of an approach for how to maybe prioritize your assessments. And next slide, please. I would say probably best to focus on people who you think are most likely to deteriorate in the near future, or people who are most likely to actually be deprioritized depending on the level of triage that you're at. So everybody under your care, if you're, for example, an MRP on the ward or an emerge, if it's not a bad idea to think about just quickly scanning over and doing an initial assessment yourself of the criteria and saying, okay, I think this person might meet level 1 criteria for deprioritization. I should probably, and if we're at level 1 triage now, I should probably take everybody who I think might be a level 1 and make sure that I do formal assessments on those individuals first, so that if there is a decision that needs to be made, it will be less time pressured, and do a full assessment on those individuals. Next slide. So again, yeah, if you're at level 1, assessing everybody whose short-term mortality risk is 80% or above, according to a screening look through. At level 2, anybody who would be 50% or above, and at level 3, anybody who would be 30% or above. And again, of course, anybody who seems close to meeting eligibility criteria or sort of deteriorating, that would be a time to do it. Next slide, please. There are tools provided to help with these calculations. Again, we've tried to put them all in one place so that you don't have to go hunt them down. I imagine that many of these, for some of these tools, that you may not be familiar with using them or may not have used them in the past. Probably good to get somebody who's at least familiar with those conditions, has expertise to use them. We've actually also got a calculator now that's online that helps calculate these and give the sort of, if you punch in some clinical information, will actually give you the answer. So those will hopefully help with implementation and short-term mortality risk calculation. Next slide. And finally, just some resources. So the CPSO statement, for those of you interested in reading it, and that's sort of supporting this process, and a folder where all of sort of up-to-date resources will be available is available at this link. And I'm going to stop there, but I imagine there may be questions later and there'll be a chance to answer them. So thank you for your attention.
Thanks, James. Obviously, it was a lot to ask of you to go over that aspect in the time frame, and really appreciate what you've done. For those not aware, it certainly goes into much more depth in the supporting documents that were sent out as part of the emergency standard of care. Certainly the triage is an aspect of it with it. Next slide. The idea of when, would this be implemented, and aspects of where it would take effect. And towards that, we are going back to Dr. Baker, who's going to be bringing up that discussion.
Thanks a lot, Dave. Yes, so I think the triggering on is one of the trickiest parts of this whole business, and I think it bears a lot of thinking about. I think I'd like to talk about triggers to activate it on and off, communication, and the regionality versus provincial approach to this, the use of this. Next slide. So I think the question of when do you decide about triggering it on and indeed off? So I think for me, it means going back to the original question of why are we doing this in the first place? And ask the question, are there any signals there about why we're doing it and whether that would help us decide when to trigger it on? And of course, when I discussed it before, Dave, a lot of my comments were quite theoretical in nature. So indeed, we would probably need proxies that reflect choosing a different direction at that juncture when we're trying to decide the best use of the next incremental resource. And of course, in making decisions like this, it's often better to choose triggers in advance to avoid the situation of over or under interpreting the situation as it exists at that point in time. Next slide. So really, what are the possibilities for those proxies that we would say are an indication of when we should take that different direction in that juncture in choosing the incremental resource? So we might look at our colleagues who look at approaches to healthcare outside of critical care and outside of COVID care. Cancer Care Ontario, for example, publishes specific wait time recommendations and guidelines for different types of cancers. Core Health looks at the prioritization of various cardiovascular procedures. And of course, access to mental health is extremely important. We may use as proxies sentinel events. So when we start to see the system failing in certain areas, especially if it's related to access to resource, this would certainly be a trigger for us to say, are we indeed directing healthcare resources in the right direction? And of course, it's not beyond the realm of possibility, Dave, for us to see a sudden, all at once, overwhelming threat to system or site integrity. And if that site was overwhelmed, we're very anxious about the situation where we may not be able to save the situation in a timely manner by simply transporting patients out to another site. And so that situation is really gripped many of us at the command center that might occur. Next slide. So we're not going to do this on our own. Let's be clear. We need, because we're in our world of critical care, and a lot of this is about redirecting resources outside of critical care, of course. And so we need to triangulate the trigger decision by listening to the perspectives that address the impact of that incremental resource issue. So certainly the OH perspective is big, and I know Chris Simpson and others have talked a lot about their concern about the now measurable impact on morbidity, mortality in non-ICU healthcare in Ontario. We would obviously listen and invite the perspectives of CCO, core health, mental health, and others, and hospitals and physicians who have a frontline view of what's going on both in critical care and outside of critical care. So we will develop in advance specific indicators, and we will integrate that in discussions at the Ontario Critical Care Command Center. There may be a judgment factor also involved in this. And finally, Dave, for better or for worse, the incident commander will have to make the final call to turn it off and to turn it on and to turn it off again. So thanks, Dave. I'll stop there.
Obviously, incredibly challenging and difficult decisions with it, and certainly none of us would take any decision like that lightly. Mike, I'm going to pass it over to you as well.
Yeah, and really important, I think, Andrew, this theme that we're integrated into the rest of the health system, and we may in some ways need to lead people to understand that we want to be a part of the discussion about the appropriate application of available resources. Can we have the next slide, Maria? Maybe Andrew, do you want to come back just a moment
I did
there?
want to miss that last slide there, Dave.
Yeah.
I do want to be clear that there will be a very clear communication broadly about the date and time for on and off. And I think that the trigger on and off will likely be provincial. And this is based on the premise that of our current strategy of active interregional load balancing. And many of you will have been aware of that critical care patients have moved from GTA Central to Kingston and to the west. And of course, being provincial would mitigate some of the border issues between regions. And it also adds confidence into our approach of the one system approach. So confidence in branding in a well-respected and coveted healthcare system where we like to think that our approach to all people of Ontario is similar. And so just to summarize this aspect, trigger on and off will be very clear, date and time, and that it will likely be provincial. So with that, I'll stop. I'm sorry.
Thanks. That's fine. That's great. Thanks very much, Andrew. And I think that really comes back to Dave's early comments. We're probably, we're much more likely to find ourselves in a situation where we have a mismatch of supply rather than, even with our efforts at kind of load balancing. And so we'll need to consider a provincial response because we're really talking about then jumping in together to try and solve that problem. Maria, we'll take the next slide.
Mike, just before we start, we'll encourage people to send questions to Q&A and not to the webinar chat because the questions will be coming from the Q&A, please. Sorry about that.
No, thanks for reminding me. Dave, I've been keeping an eye, and it looks like people have been very engaged in the chat, and so that's terrific. Certainly, one of the aspects that people are, as Andrea pointed out earlier, comes to top of mind are the issues around what might be the implications of doing this. To help us through that, we've got three experts who will give us their perspective on what those implications might be. Daphne Jarvis is a partner at Borden, Ladner and Gervais. She's a civil litigator specializing in health law, and particularly the representation of hospitals and their employees in medical malpractice claims and a variety of other legal matters. Dr. Stephen Bellemare completed his residency in pediatrics at the University of Alberta, and he specialized in child maltreatment pediatrics. He was an assistant professor at the Dalhousie University and worked as a member of the child protection team at the IWK Health Center in Halifax before he joined the Canadian Medical Protective Association in 2009. Stephen is now the Director of Practice Improvement at the CMPA. And Martin Lattner is a partner at the Ottawa office of Gowling WLG. His practice focuses on health law and medical defense, with an emphasis on privacy and e-health matters, including acting as a counsel for the Canadian Medical Protective Association and physicians. So Daphne, I think you'll start us off, and Maria, you can advance the first slide.
Thank you. So as you've heard, I'm a health law lawyer who advises and defends hospitals. And in that regard, I've been carefully following the issue of critical care surge planning and triage, and have been consulted by several hospitals over the past several months, which is probably why I've been asked to address this issue from the legal perspective today. I could talk all day about it, but I have 5 minutes. It's incredibly difficult to put this into a 5-minute nutshell, but I have 3 slides, and that's what I'm trying to do. So please advance the slide. So generally speaking, broadly speaking, we know that the goal is to provide care that both meets a reasonable standard and without breaching the law that's also pertinent to the implementation of surge capacity planning and triage. As of today, the law, as gray as it might be, and to the extent that it's relevant to these issues, has not changed. Brief reminder that when it comes to the standard of care to which health professionals and providers are held, it's a reasonable standard. It is never a standard of perfection. And any standard of care analysis always inherently considers all of the relevant circumstances that are pertaining at the time that the patient is presenting for care. So this surge situation that we are anticipating is one of these circumstances that is going to affect the standard of care. And as you've heard, it means that the focus shifts from optimizing individual care to maximizing population health outcomes. So that concept may be new to us, and I can't say that we have a body of Canadian case law specifically addressing a pandemic critical triage situation, but there is a body of case law and medical legal literature that is broadly speaking relevant and which supports this concept. Next slide. So, as you've heard, the document, it's more than one document, but the document which outlines the standard of care represents a very broad professional and expert consensus that has been developed over a long period of time and with a huge amount of work. And it's the emergency standard of care that assumes no change in the law. It provides clinical guidance with respect to the assessment of a person's short-term mortality risk, which in turn determines what interventions will be offered or not offered depending on the level of surge then prevailing. So it is both guidance to clinicians as to a clinical assessment, and it's also guidance to the system as a whole as to the allocation of scarce resources when that situation is prevailing. Big reminder here that there is no legal obligation to offer treatment which lies outside the standard of care. That is, consent is not required not to offer non-standard treatment. So a change in the standard of care because of emergency circumstances does have an effect on what treatment one must offer or is free not to offer. Next slide. The issue that Andrew just addressed briefly, what's the legal impact of there being regional differences in surge capacity? And just to emphasize that it is the same standard of care. Basically, we're expecting that most, if not all, healthcare providers would conduct themselves in a similar manner in the same circumstances. And the fact that it is a province-wide standard of care is a very significant strategy of risk mitigation from a legal perspective. You've heard some of the risks of not implementing it, such as more preventable deaths and preventable deaths of individuals who in fact would benefit from critical care. And in that situation, one can understand why the risks of non-implementation might be more than the risks of implementation. So in short, it's a best way to mitigate legal risk and to focus in a good faith effort to reduce morbidity and mortality. That's it for me. Thank you.
Thanks, Stephanie. Stephen?
Thank you very much. We can advance to the next slide. So Marty and I are happy to be here to present a quick overview of why the issue of the emergency standard of care is of such importance to you. Martin will be much more scholarly in answering some of the legal questions, and given that we only have 2 slides, I'm going to present both of them. We can move on to the next slide. As Daphne was mentioning, not only is this emergency standard of care an important step in decreasing the medical legal risk that you might face as a physician, or even that a hospital might face, but more importantly, it's also a critical way to ensure that every patient has just, equitable, and consistent access to a limited resource, which is critical care. And so by enacting an emergency standard of care, essentially we'll be making sure that everyone in Ontario on a population basis gets treated the same way. So why is the standard of care important? That's because the standard of care is at the heart of any medical legal matter, be it a lawsuit or college complaint or a hospital complaint. If you were to face a lawsuit with regards to a choice to not provide critical care services to a patient, for instance, the court would then seek to answer the question, what would a reasonable physician of similar training and experience have done in a similar circumstance? That's how it will determine whether or not there was negligence at play. And so the question then becomes, what would other docs like you in critical care have done in Ontario at that time? Not in British Columbia, not in Quebec, because every province is going to have a different approach to that. So the standard of care usually is derived from expert opinion. We have experts who are physicians of similar training and experience in similar circumstances as you would be, who provide opinions to the court as to what they would have done in that circumstance. Often there's opposing opinions, and then the judge or the jury has to decide which way to go, which way to decide to choose whether or not the care was reasonable. So the peer experts set the standard of care, and the standard of care changes over time. The way we treated a condition in 1980 is not the same way as we treat the same condition these days. There are other ways that we can get to the standard of care, and that includes looking at guidelines or protocols that are published by various regulatory bodies like the CPSO in this case, or by national specialty societies. Finally, very rarely, governments can impose a standard of care. So that'll be the case in Quebec, for instance, where their emergency triage protocol, if it goes into effect, will be done by decree of the Minister of Health, who will say, from now on, this is how we are going to decide who gets access to care. That's not the case in Ontario. This is why we're talking about here the emergency standard of care, and that's not chosen by luck, because this standard of care was created by your peers. It was created with input from critical care specialists. And as such, if and when the COVID Command Center decides to decree that it will go into place, it will be de facto the way your colleagues will expect you to behave in a time of crisis. And so it will be the way to practice. It will be the standard of care and what your peers will accept. We're going to move on to the next slide. So with that said, the key message that I want you to hear today is that the CMPA is there for you. And we realize how difficult this crisis has been and continues to be, and how even more difficult it could be if we're at the place where we have to enact an emergency standard of care. We've always been there for you and will continue to be there for you. So my message is really, don't worry about the potential for medical legal problems. Don't worry about the potential for a college complaint or a lawsuit, because sometimes despite your best efforts, they can still happen. We will not let you down. We'll be there to protect you at those moments. You can call us anytime you want for advice if you have specific concerns, but what this means to your patients, to your practice in real time. And be aware that the CMPA is always working with governments and with HIROC, which is the insurance company for the hospitals, about this issue. We're in constant communication. We make representations on your behalf to make sure that if and when this goes into place, you'll have the best protections possible. So I'll leave it at that, and then we'll be happy to answer more questions later.
Well, thank you, Stephen. That was, and Daphne, that was really very, very helpful. We have a couple of housekeeping items. We noticed that some people have gone ahead and raised their hands, and I just wanted to remind folks that in this circumstance, we're actually not going to have the attendees speak directly. We do have a facility in the chat, or pardon me, in the Q&A, as Dave has pointed out. That's going to be our vehicle to be able to identify topics, ask questions. There's a feature there that you can upvote questions that you want to support. If the questions come in quantity, then the upvotes move those questions to the top of the pile, and it will be easier. As Dave pointed out, our colleagues, Dr. Theriault and Adhikari, will be kind of moderating those questions, and they'll be asking, feeding those questions forward to the panelists through David and I. Dave, I got to tell you, we managed to put this together in less than a week, and what we've asked from our panelists has been extraordinary. I can't tell you how, from my perspective, just how tremendous they have been, and from my perspective, what a great presentation they've given us.
Certainly, I echo those comments. It's always amazing when you see it take shape, and so certainly most appreciative of the presentation and the conciseness, but the thoroughness, and it was nice to end on a positive note with Stephen. So certainly that is certainly reassuring. So as alluded to by Mike, we'll be using the Q&A feature, and towards that end, I'm going to start with Dr. Theriault, who's going to ask a question, and then we'll go to Dr. Adhikari after which. So please take the time to upvote on the Q&A, and we invite all our panelists to stick around, and we'll do our best to get through as many questions as possible. We're looking at about another half hour. Jose, do you want to start us off?
Yes, thank you. Thank you, Dave, Mike, and thank you to all our speakers for a superb presentation. Lots of questions coming in, so I like it, and voting also is coming in. I think some of the questions that are coming in have to do with a bit of a difference between the emergency standard of care and the triage protocol that we had seen circulated. So mainly considering not offering from a standard of care versus withdrawing. So I think if we could start with a bit of that difference, clarifying that difference, I think it would help.
Andrea, maybe you can take that question.
I can jump in, and others can echo. So we want to recognize we are using the word triage to describe the situation of the allocation of a scarce resource in a way that is fair and transparent and equitable, and in alignment with this standard. So the STMR and the tools are basically identical between the emergency standard of care and a protocol that would include the provision to allow for the rare occasion when withdrawal of life-sustaining treatment in the ICU would be required without the consent of the patient and family. To allow that particular aspect of the Healthcare Consent Act would need to be altered by an executive order of cabinet. And it was felt that while that executive order is not currently in place, it was very important to begin to socialize the emergency standard of care, the STMR tools, and to prepare our communities, our healthcare colleagues, and healthcare system for implementation, whether or not the executive order comes down. But there is a lot of concern around the province amongst clinical colleagues and advocates around really ensuring that there is equity in the application of this standard, recognizing that without the executive order, it could introduce inequity where it would only apply to people waiting for critical care or people who become critically ill later. And it doesn't apply to people who already have the benefit of critical care, who happen to sicken earlier and are already in the ICU. So there are many conversations happening with members of our government and Critical Care Command Center and other stakeholders to really try to work out how to proceed. But I think the important thing at this point is to continue to socialize the emergency standard of care, get familiar with these tools, prepare your organizations and your regions for implementation, and to stay tuned, as Dr. Baker has indicated, that when this document or this process does get triggered, that there will be clear direction around how it gets implemented, where it gets implemented, and whether it is the emergency standard or the protocol that includes patients already in ICU. So I hope that helps to disambiguate. I'm not sure if other members of the panel also want to respond.
Sure, I could chime in. This is Marty Lappner. So just to go back about the distinction between withdrawal and withholding care, this largely arises from the Razzouli decision of the Supreme Court of Canada from a few years ago that said that sometimes withdrawal of care constitutes treatment under the Healthcare Consent Act, which then requires consent. So in those cases, withdrawal can't happen unilaterally by the healthcare team. And it's important to note that, and this was Dr. Froelich spoke to this, that the emergency standard of care doesn't include that. That is not included in the document. If this were included, that would require an emergency order by the government, an executive order, stating that the Healthcare Consent Act does not apply to those cases, and to authorize healthcare providers to do that. The Healthcare Consent Act doesn't broadly obligate a physician to provide treatment. That therefore incorporates the withholding of care in the emergency standard of care document. So the assistance that this document provides is that it helps to establish an applicable standard of care in these exceptional circumstances. So I just wanted to note that.
Dave, may I just comment?
Yeah, we'll go to Andrew and then we'll go to Neil for another question. Certainly it's a complex question, but Andrew, do you want to comment on it as well?
Very briefly, just to add to what has already been said, I won't repeat that, but there's a couple of practical applications, of course, and that is that the emergency standard of care that contemplates focusing only on withholding. Of course, there is the imperative to think about patients who may be coming at a later time. And so if you look at it from a perspective of trying to maximize the number of lives saved, you would have to initiate that earlier. And I think that a protocol with the that contemplates including withdrawing invasive physiologic support would have two attributes to it. One, you would institute it or trigger it later. And second, you'd probably obviously have trials of therapy more commonly because you knew you had that provision. And so for a number of reasons, there are fewer preventable deaths with the protocol that incorporates the possibility of withdrawing invasive physiologic support. And so there are some people who emphasize how tough it is to actually do that withdrawal, and other people who emphasize that errors of omission in not producing the protocol should be equally ranked and point to the difference in the number of preventable deaths. So thanks, Dave.
Yeah, it's a very, very difficult subject and issue. The idea that not offering because there's not the provision of being able to withdraw, may actually have an adverse impact on the number who are actually receiving care. And that's sometimes initially a hard concept to understand, but makes a lot of sense when you think about it in greater depth. In the interest of getting other questions, we'll go to Neil Attakari and see what he has, and certainly we'll do our best to address as many questions as possible. Neil?
Yeah, thanks. Certainly many questions coming through on the Q&A, and thanks people for asking them. One question that's received a lot of support gets to the issue of dissemination of this strategy and this information to the public, so that there's some expectation well in advance of the declaration that the emergency order is in effect, that it might be coming down the pipeline. So I wonder if panelists could talk about that. And second, it seems that many people have commented in the chat and a little bit in the Q&A about the fact that the resources are not easy to find for clinicians, and maybe some discussion about that as well. Thank you.
Perhaps Andrew can start with the dissemination, and then we can go to James or Andrea about where to find the available resources.
Yes, I think it's exceptionally important for our group and the system in general to be completely transparent. And the more problems are created by the appearance or the actual withholding of information that are created by sharing it openly. I think the Canadian Critical Care Society published a really excellent piece in Maclean's, and I think that starts the process of having public media discussion and awareness of this. I think we certainly intend to have pieces coming from the command center in public media. We will have a communication strategy. And we will ask for support from that from both the Ontario Health and the Ministry of Health. But I'm committed to that transparency. And I sort of completely agree with the question. Maybe Neil, I can leave the question of resources to somebody else like James or others on the panel.
James, I know you've already put a bit in the chat. Do you want to talk about the resources, and then Andrea can support that as well?
Yes, sorry about that. I've been, my fingers are getting sore from trying to type answers. Thanks for the questions. I think our hope is that obviously Andrea has made the MacDrop folder available with a lot of resources. There is a presentation, PowerPoint presentation that goes over this that has a very, hopefully not too sleep-inducing voiceover narrative that will walk you through the slides, and along with the calculator and links to the calculator itself and tools to help people. And I think it's a good idea to get familiar with those as you go along the way. Again, it goes without saying that it would have been really nice if COVID could give us another 10 months on this one, and then we would really be able to do this properly. We're in a situation that is not of our design. We're doing what we can with what we have in the time that we have. And, we're hopefully that sort of with local implementation teams taking these resources and adapting templates to suit local contexts, that we can really get this as good as we can get it in the time that we have. And I hope it's enough. Again, my email, I will put it in the chat box. If you have specific requests or any suggestions for material, guys, we're all on the same team here. And let's face it, none of us have been in this scenario before. So if you have good ideas or something that you're doing at your institution that you'd like to let others know about, please do let us know. And we'd be really happy to sort of spread that around. Andrea, I don't know what you want to add or subtract from that.
One of of the ways in which the issue of resources is arising is thinking about not all communities, not all hospitals, not all regions are resourced the same way in terms of their access to physicians, their access to other health professions, their access to other administrative supports. And so I've been in extensive conversation actually with Jose about the adaptation of this a standard of care to the north, which is differently resourced than Ontario West and differently resourced than University Avenue, downtown Toronto. And I think what's important about that is to recognize we've tried to create a standard of care that is relatively bare bones in the sense of it focuses on how the clinical assessment of the short-term mortality risk is done at the bedside, at the interface with the clinician, the patient and family, and really kept the administrative infrastructure relatively minimal so that it can be adapted to the available resources within your locality. And so I think it's really important for you with your chiefs of practice, with your directors of service, with your hospital administrators and regional leaders to get together and say what makes sense in terms of operationalizing this standard of care, yes, at the bedside, but in an equitable way and a sustainable way, given the resources that we have. So we really do encourage adaptation of the infrastructure, even though, of course, the goal is to implement it in a standardized way across all provinces. So there is some flexibility for adaptation there. And I hope that gives you some opportunity to apply your creativity around how to make this work for your community within the resources you have, but also potentially partnering with more resource-rich regions through virtual care, through virtual support platforms in order to enable more equity of access to supportive resources as well.
Excellent thoughts there, Andrea. Truly appreciate that. I'm going to go to Stephen, who I think is going to give another perspective as well to add to this discussion.
Yes, thank you, Dave. Just in follow-up to Andrea's comments, one of the key issues to consider is to think about whether or not the people in your hospital, in your team, have clarity with regards to the intention of the emergency standard of care and with regards to its application. It's meant to standardize the approach, but again, even though you may read the same document, people may think of it differently and interpret it differently. It goes a long way to help make sure that things are standardized and protocolized. But I think we have to think seriously about the value of simulation in applying this protocol. If you play a leadership team in your hospital, I would invite you to think about when is the time to actually start running some drills to apply this protocol, because the time to start thinking about these issues is not when it is decreed that it is going into application. It's right now, which is why we're having these conversations. And so again, if you're looking at it from the point of view, whether you're looking at it from the point of view of patient safety and equity, or even from the point of view of medical legal risk, the intent of this protocol is to try to take as much subjectivity out of the hands of the individual docs and to make it as clear and standardized for everyone. I invite you to think about that, and even as to whether or not your hospital will have a team looking at these decisions, or whether or not, because the protocol allows for deciding at the individual level, will these decisions be made individually by a treating physician or by a team? So that's something that you're going to need to think about obtaining clarity for your individual units.
Thanks very much, Stephen. Dave, I just wanted to point out that in the chat, Jose has dropped in a couple of times now the address for the Mac drop box. So there are some really very useful resources there and accessible to anybody who's who's
excellent point, Mike. And I would also believe we can create the links at CCSO's website and things as such in some fashion, or they could be redirected from there as well. So I think it's important that the resources that people recognize that they are available, and certainly to go to the Critical Care Services Ontario website to help with that. I would also just remind people that to do their best to fill out the survey. I do want to thank the team from CCSO. This has been a lot that we have asked of them. So Maria and Lynn, Bernard, the team has done a wonderful job putting this on, like literally in a very short time frame, and learning a new platform. So certainly, you know, before at the end, I would like to recognize the time and effort they have done. I think we're also going to copy the chat in the Q&A, and we'll do our best to figure out a way to hopefully try to address it, since clearly time is our enemy. And so we'll see about an alternative strategy for that, and we'll do our best with that. So I'm going to go back to Jose, and I know Andrea wants to comment on something as well, and we'll get to that as well. So Jose, do you have another question that you can bring to our panelists' attention? And then we'll go to Neil, and then we'll have Andrea comment as well.
Thank you, Dave. Yes, absolutely. There's some questions that are getting a lot of attention. So one of the questions actually brings a little bit of a challenge, and especially from a frontline physician, having to apply the standard of care in patients that actually have critical care treatment started in the field and are brought to the emergency department already on critical care support. So this emergency standard of care does not allow us to withdraw care, but how do we face these patients and these decisions as frontline physicians? So anybody?
That sounds like a James question to me.
Thank you.
Yikes! I'm terribly sorry. I was frantically answering in the Q&A. Could you repeat the question, please?
Hi, James. One of the challenging questions as frontline physician is for patients that receive critical care in the field by EMS Orange and are presented to the emergency department already intubated, ventilated, resuscitated. So how does one as a frontline physician deal with the emergency standard of care when we know that this patient may not benefit?
Add this to the long list of very good reasons why we should have an executive order to allow withdrawal for allowing for equity, because we need to, I think, decrease the consequences of people, mistakenly intubating somebody who should not have been prioritized. You want to make it very easy for people to offer critical care and not make the mistake of not offering it and only finding out later because they made a hurried decision that they should have. That's what you don't want. The ability to withdraw is the ability to offer in marginal or higher mortality risk cases. That's the way to look at it, right? That's why it would result in better outcomes for everybody. I know that the ambulance services and emergency services are aware of this document. We had conversations with them early in the spring, and they have a sort of surge practices already available where they are going to look at situations where, certain types of resuscitation, they would not initiate resuscitation, certain scenarios. And they are aware of this document. And to the best of my knowledge, they certainly did in the springtime align their practices. Their standards would change in a way that would reflect this document. So for example, if we hit a maximum surge, that they would not attempt certain type resuscitation, cardiopulmonary resuscitation, and lower levels of surge, they would resuscitate people only in situations like having a witnessed arrest and a shockable rhythm, for example. To your point, they should be aligned, and they are. The emergency services are aware.
Would that information be available to be able to consult as well as the emergency standard of care for all practitioners, and especially the frontline emergency physicians?
I can't speak for the emergency services, but I can speak to them. And we can certainly, we'll make a note to reach out to them and see. I think, this is happening in a dynamic way, and obviously, I'll go back to my wish we had 10 months comment. We don't. We're doing our best.
I certainly think it highlights the challenge of the situation, but it's also to stress the importance of courage, for everyone to be in this together, to work as a team, to recognize the rationale behind this, and that we're here trying to provide care to all patients and with it. And so, there will always be nuances and difficulties with it, but I think it's important for all of us as health professionals and leaders to reach out and to work together on this. And so to share the reasons for it with the emergency medical services and other related groups, because the rationale behind this, as has been alluded, has been worked on and is to address the care for all patients with them. But certainly there will be challenges. Neil, do you have a question? And then I think Andrea was going to follow up on an important point.
There's a question here about the transfer of patients outside of their catchment area to other hospitals. I presume it's part of load sharing before this emergency standard of care is enacted. Question of whether it would be COVID positive patients versus negative ones, given that rates of infection and hospitalization in Northern Ontario are a lot lower.
Perhaps Andrea, you want to comment, because I know you've been quite involved with this, as has Mike and myself.
I think that, first of all, I think it's the expectation for any hospital, all hospitals in Ontario, to be prepared to receive COVID positive patients, either through transfer or naturally occurring. So that our expectation is that all hospitals are capable and ready to receive COVID positive patients. The load balancing philosophy and strategy is one where we have, is about COVID positive patients, Neil, and it's about sharing that load if you like, being so that all areas of the province would have a proportionately similar contribution to this new disease, and then could address other non-COVID disease over and above that shared contribution to this new disease. So certainly it might occur that we would load balance through sending non-COVID patients, but the plan is to send COVID positive patients.
Thanks, Andrew. Andrea, I think you were going to address the difficult discussion point of how do you present it to the patients and their families, and what can be done and what is available.
Yeah, I really appreciated the comment in the Q&A that we should stop using the term withdrawing care. I really appreciate being called on that, because in fact, care should never be withdrawn from patients, but certain treatments, specifically invasive treatments, might be withheld or withdrawn in this context. And I think one of the ways that we can continue to form trusting alliances with patients and families is by emphasizing what we will continue to do. We will continue to medically manage patients. We will continue to palliate patients. We will continue to offer psycho-emotional support and comfort care. I think one of the ways that we can best form alliances with patients and families in the face of this standard of care is, first of all, to have the goals of care conversations. So we're really, where possible, aligning what the goals and wishes of patients are and creating a care plan on the basis of that. I think secondly, we should be pulling together our interprofessional team. This is a physician practice standard, but it has enormous implications for that bedside nurse, for the social worker, for the chaplain. And so in anticipation of these difficult conversations, which may provoke anger, which may provoke despair, which may provoke incredible grief and anticipatory grief and sorrow for patients and families, how can we create a kind of whole person care model around that situation where our interprofessional colleagues can lean in and stand shoulder to shoulder with us in supporting those patients to recognize and to move toward some recognition and acceptance of the situation, but also continue to focus on what we can do collectively for our patients and families. So this is not to diminish how difficult those conversations may be, but in anticipation of that, to provide the resources, tools, and supports that are available to us in our health system. And to recognize that almost every day in our hospitals, we are saying no to patients who want treatments, patients who wish they could have an organ transplant, patients who wish they could have an experimental therapy, patients who wish they could get bumped to the front of the line for the surgery they've been waiting for so long. We have these difficult conversations about limited resources with patients and families every day. So how do we draw on that wisdom and the strength of our teams to support us and support our community?
Thank you, Andrea. Very, very important comments and huge significance. I'm recognizing we're at the end of our time. I'm not sure if we can push it a little additional time, if our panelists are willing to do so. Mike, what do you think?
Well, Dave, I think we should probably wrap it up. I think people have been here. We've asked people for a lot to come out on a Saturday. Obviously, there's lots and lots of interest in this. I think what we ought to plan to do is look over the chat and the Q&A and try and distill out some topics. I think there's enough here that through the OC3PR mechanism, we may well come up with some additional pieces to be able to drill down to some of the major topics that are that kind of come out of those chats. I'm just really conscious of how much we've asked these people, and I want to be fair.
You're much more of a gentleman than me. Like, you've always been that way, and I certainly respect that. And as always, I defer to your knowledge, and certainly I respect that. So I just want to echo the comments. I certainly very appreciative of all our panelists taking the time on a Saturday. Now, let's recognize it's January. It's not like we did this in July, but certainly the time and effort that went into this, and certainly short notice, we are very, very most appreciative of this. I would like to highlight that our intent is to post this at Critical Care Services Ontario, along with their YouTube site. And so the material will be available with it. I do know that, you know, I look at the Q&A thing saying 48 questions. So we are going to do our best to collate all of this and try to come up with a strategy on how we can best help you, the listener, the people on the front line dealing with this issue. And so again, I just want to say thank you to everyone. Please take the time to do the survey that will be sent out. It is invaluable for us going forward. And as always, I'd like to give the final word back to Mike there, and very appreciative of him taking the time.
David, thank you, and thanks for all the great work you've done, kind of moderating and chairing these sessions, these OC3PR sessions. I think I just wanted to kind of close a little bit, coming back to your opening comments. You know, I know it's distracting and unsettling when we're talking about these topics about the, you know, kind of usual care and our emergency standard of care and a triage protocol. And it's easy enough to, it's very emotive and concerning to be caught in the issue about, you know, trying to be as perfect as possible with withdrawal of care. And Andrea, I'm going to come back and just highlight for myself to really make sure that I'm talking about not withdrawal of care, but about the fact that we want to, you know, alter or limit the care, limit access to ICU for people perhaps who are not there. I think the thing I wanted to really stress is those kind of discussions happen all of the time now. Many people who are in the circumstance of critical care will, with a thorough discussion, with their having either highlighted their concerns ahead of time or with their family, decide that that's not the case. I also wanted to kind of point out how dynamic that situation would be if we were actually in the circumstance where we got to an emergency standard of care. And so I can imagine that my conversations with families would be very, very different when all of this is on the front page of the Globe and Mail, and people's families are doing things that where they're hoping that people can have access to the hospital at a time. So I just want to kind of emphasize to people to not spend too much time over there. I think this is a very important step contemplating the emergency standard of care. There's work to be done there, really good work. And to your point, I think I would just want people to be courageous enough to start on that work, to do as Stephen pointed out, to start to do some simulation, to get the documents in their hands and to start to figure out how to use this. And so thanks again to all our panelists, and we'll see you at our next session of the OC3PR, which is learning from our practice, how clinical studies enrolling critically ill COVID-19 patients from all ICUs can improve care. And I think I want to put the emphasis on the all ICUs piece. This is really talking about how our entire critical care community in Ontario, our academic hospitals and our community hospitals can contribute to research on COVID-19. So thanks a lot, folks. Enjoy the rest of your Saturday. We really appreciate you joining us.
Thank you.